This podcast is brought to you by JAK2. All the chaos of a myeloproliferative neoplasm, the overabundance of red cells, the excessive platelets, can often be traced back to this one single, ridiculously simple mistake in the DNA's alphabet. It's the genetic equivalent of a bored office worker leaving the "make more cells" button jammed in the on position, leading to a spectacular and tragically unnecessary overproduction of blood cells.
Welcome back to the Deep Dive, where we go beyond the result and into the why.
In our last episodes on myeloid neoplasia, we've covered some really heavy hitters. We started with the chaos of acute myeloid leukemia, that explosive proliferation of immature blasts. Then we moved to the frustration of the myelodysplastic syndromes, or MDS, the factory that's working hard but producing defective, dysfunctional cells.
Exactly. AML was about a failure to mature. MDS was about ineffective, dysplastic production. Today, we're tackling the third major category of myeloid neoplasms, and in many ways is the conceptual opposite of MDS. We're not talking about a factory that can't produce, we're talking about a factory where the production line is stuck in overdrive.
A factory with the gas pedal welded to the floor. Today, we are diving deep into the myeloproliferative neoplasms, or MPNs. These are clonal stem cell disorders defined by the overproduction of mature, functional-appearing myeloid cells. We're talking too many neutrophils, too many red cells, or way too many platelets.
And as medical laboratory scientists, this is where we shine. The clues are everywhere. The CBC, the differential, and most dramatically, the peripheral smear. Our goal today is to connect the molecular driver of each disease directly to the findings we see at the bench. We'll unpack the pathophysiology of the four major players: chronic myeloid leukemia, polycythemia vera, essential thrombocythemia, and primary myelofibrosis.
It's a journey from a single mutated tyrosine kinase all the way to a smear that can be so packed with cells you can barely find a clear field.
So let's get started. What's the unifying theme here? What makes an MPN an MPN?
The central mechanism for almost all MPNs is a mutation that causes constitutive or constant activation of a signal transduction pathway. Think of these pathways as the internal communication network that tells a cell to grow and divide. Normally, a growth factor has to bind to a receptor on the outside of the cell, like a key in a lock, to turn this signal on. But in MPNs, a mutation happens downstream from that receptor. It's like someone hot-wired the system. The cell gets a relentless internal go signal even without the external key. This signal is often mediated by a class of enzymes called tyrosine kinases, which act like on-off switches. In MPNs, a mutation locks one of these switches permanently in the on position.
And that brings us to the first and perhaps most famous MPN, the one that literally defined the concept of a specific genetic abnormality causing a specific cancer. Let's talk about chronic myeloid leukemia, or CML.
Right, and it's so important to remember what that is. It's not an extra chromosome or a missing one. It's a reciprocal translocation between chromosome 9 and chromosome 22, written as T922. A piece of chromosome 9 containing a gene called ABL1 breaks off and attaches to chromosome 22, right in the middle of a gene called BCR.
And this mashup creates a brand new monstrous fusion gene, BCR-ABL. And the protein this gene produces is the ultimate culprit, a constitutively active tyrosine kinase. It's the ultimate go signal, specifically for the granulocytic cell line.
It tells the myeloid precursors to proliferate uncontrollably and also makes them resistant to apoptosis, or programmed cell death. So you get massive overproduction and increased survival of granulocytes.
And that pathophysiology perfectly explains the classic lab findings. Let's start with the CBC. What do you see?
You see a CBC that gives you whiplash. We are talking about a sky-high white blood cell count, often over 100,000, sometimes 200,000 or more. The primary cell line is neutrophils, but what's truly characteristic is the left shift.
And that's a key term. A left shift means you see the entire spectrum of neutrophil maturation in the peripheral blood. The bone marrow is churning out cells so fast that the whole conveyor belt spills out into circulation. So when you do the manual differential, you don't just see segmented neutrophils and a few bands. You see metamyelocytes, myelocytes, promyelocytes, and even a few blasts. It's a beautiful, terrifying parade of granulopoiesis.
A parade is the perfect word for it. And two other critical findings on that differential are absolute basophilia and often eosinophilia. That prominent basophilia is a real hallmark of CML, directly driven by the BCR-ABL1 fusion. If you see a massive neutrophilia with a significant left shift and crucially basophilia, your CML alarm bells should be screaming. The platelet count is also often elevated, sometimes dramatically.
So then you take it to the slide. You see this sea of myeloid cells. And how do you as an MLS distinguish this from a severe infection, what we call a leukemoid reaction, which can also have a very high white count and a left shift?
This is where classic hematology comes in, and where we add immense value. A leukemoid reaction is a physiologic, appropriate response to a stimulus like a severe infection. Those reactive neutrophils are healthy and functional. In contrast, the CML neutrophils are neoplastic. They may look mature, but they are functionally abnormal.
And we have a test for that, or at least we used to, the leukocyte alkaline phosphatase, or LAP score. You're standing neutrophils for the activity of this enzyme. In a leukemoid reaction, the neutrophils are hyperfunctional, so the LAP score is high. In CML, the malignant neutrophils are deficient in this enzyme, so the LAP score is characteristically low. While molecular testing has largely replaced it, understanding the why, functional versus dysfunctional, is still a core concept.
Absolutely. And on the smear, in a leukemoid reaction, you'll often see signs of infection like toxic granulation, Donley bodies, and vacuolization. You typically don't see those in the chronic phase of CML. The other huge clue, again, is that absolute basophilia. You just don't see that with infection.
Okay, so the CBC and smear are pointing strongly to CML. What's the definitive diagnostic step?
It's all about finding the culprit. Historically, it was cytogenetics, looking for the physical Philadelphia chromosome in the bone marrow karyotype. Today, the gold standard is molecular testing. We use PCR or FISH to directly detect the BCR-ABL1 fusion gene. It's incredibly sensitive and specific. Not only does it confirm the diagnosis, but we can use quantitative PCR to monitor the patient's response to therapy.
And that therapy is another perfect example of pathophysiology-driven treatment. The development of tyrosine kinase inhibitors, or TKIs like imatinib, was revolutionary. These drugs are designed to fit perfectly into the BCR-ABL1 protein and block its activity. It turns the stuck-on switch back to off. It's a remarkable story of bench-to-bedside medicine.
A true triumph. CML went from a disease with a 3 to 5 year survival to a manageable chronic condition for most patients, all because we understood the single molecular driver. A fantastic summary of the OG myeloid proliferative neoplasm. Now, let's shift gears. CML is defined by BCR-ABL1, but there are 3 other major MPNs that are BCR-ABL1 negative or Phe negative. These are polycythemia vera, essential thrombocythemia, and primary myelofibrosis, and they share a different but related molecular pathology.
Exactly. The vast majority of these cases are driven by mutations in one of 3 genes, JAK2, CALR, or MPL. The big one, by far, is JAK2. The JAK2 protein is another tyrosine kinase, a critical part of the signaling pathway for multiple growth factors, most importantly erythropoietin, or EPO, which drives red cell production, and thrombocytopoietin, or TPO, which drives platelet production.
So it's the same theme as CML, just a different switch that's stuck in the on position. The most common mutation found in over 95% of polycythemia vera cases is called JAK2 V617F. This single-point mutation makes the hematopoietic cells hypersensitive to growth factors. They can proliferate even with very low levels of stimulation.
Let's start with the one that's most defined by that JAK2 mutation, polycythemia vera, or PV. The name says it all. Poly meaning many, cythemia meaning cells in the blood. This is a disease defined by the overproduction of red cells.
So on the CBC, the immediate flag is a markedly elevated hemoglobin, hematocrit, and red blood cell count. This is the definition of erythrocytosis. But because the JAK2 mutation is in an early stem cell, it often affects the other lines too. So it's not uncommon to also see a mild glucocytosis and a significant thrombocytosis. We call this panmyelosis. All myeloid lines are cranked up.
So when you see that absolute erythrocytosis, your first thought is this PV or is this a secondary reactive process? For example, heavy smoking or chronic lung disease can cause hypoxia, which makes the body appropriately produce more EPO to compensate, leading to more red cells. How do we in the lab help differentiate?
This is another beautiful example of pathophysiology in action. The key test is the serum EPO level. In a secondary reactive polycythemia, the body is producing more red cells because the EPO signal is high, so the EPO level will be normal or elevated. But in polycythemia vera, the JAK2 mutation is causing red cell production independent of EPO. The body sees all the excess red cells and, through its negative feedback loop, shuts down kidney EPO production.
So the classic pathognomonic finding for PV is the combination of a high hematocrit with a suppressed low serum EPO level. The factory is churning out red cells even though the foreman, EPO, is yelling stop. The diagnosis is then confirmed by finding that JAK2 V617F mutation.
Precisely. The patient's main clinical risks are from the blood being too thick or viscous, leading to a high risk of thrombosis, like strokes and heart attacks. And the main treatment is surprisingly low-tech. Therapeutic phlebotomy. They literally just remove blood to get the hematocrit down to a safe level.
Okay, so that's PV, the red cell predominant MPN. What about its cousin, essential thrombocythemia, or ET?
If PV is about too many red cells, ET is about a massive sustained overproduction of platelets. The diagnostic criterion is a sustained platelet count over 450,000, often reaching well over 1 million.
And the molecular drivers are the same family we just discussed. About 50 to 60% of ET patients have that JAK2 V617F mutation. Most of the rest have mutations in either CALR, calreticulin, or MPL, the thrombopoietin receptor gene. All three mutations ultimately lead to that same outcome, a stuck-on signal for the megakaryocytes, the platelet parent cells.
So you get a CBC with an isolated extreme thrombocytosis, you take it to the smear. What are you looking for?
First, you are visually confirming the thrombocytosis. You'll see sheets and clumps of platelets. But you also look at the morphology. You'll often see giant platelets, what we sometimes call megathrombocytes, and hypogranular platelets. It's not just a quantitative problem, it's qualitative too. The bone marrow in ET is characterized by a marked proliferation of large, mature-looking megakaryocytes, often with hyperlobated or staghorn nuclei.
The big challenge for us here is, again, distinguishing this clonal process from a reactive thrombocytosis. Iron deficiency, inflammation, surgery, cancer, all these things can cause the platelet count to rise.
And the key is threefold. First, the degree of elevation. A reactive thrombocytosis rarely goes above 1 million. In ET, it frequently does. Second, the chronicity. A reactive process should resolve when the underlying cause is treated. In ET, the high platelet count is sustained for months or years. And third, the ultimate confirmation is molecular. Finding one of those driver mutations, JAK2, CALR, or MPL, proves it's a clonal neoplastic process.
A perfect breakdown. That brings us to our fourth and final MPN, and in many ways the most dramatic and devastating of the Philadelphia chromosome negative group, primary myelofibrosis, or PMF.
PMF is a fascinatingly tragic disease. It often starts like the other MPNs, with a hyperproliferative phase driven by the same mutations, JAK2, CAL, R, or MPL. But the key feature is what happens next. The malignant clone, particularly the abnormal megakaryocytes, are terrible neighbors in the bone marrow.
That's a great way to put it. These abnormal megakaryocytes release a flood of cytokines and growth factors, like platelet-derived growth factor and transforming growth factor, beta. These signals don't stimulate more blood cell growth. They stimulate the non-neoplastic fibroblasts in the bone marrow stroma. And they tell those fibroblasts to produce collagen and reticulin fibers.
So the bone marrow literally becomes scarred over. This progressive fibrosis slowly chokes out normal hematopoiesis. The factory gets paved over with scar tissue. As a result, blood cell production is forced to move outside the bone marrow to other organs, primarily the spleen and liver. This is called extramedullary hematopoiesis.
And this pathophysiology creates the most dramatic peripheral blood smear in all of hematology. Let's start with the CBC. It's often variable, but the classic picture is anemia because red cell production is so impaired. But it's the smear that tells the whole story. You see 3 cardinal features. The first is dacrocytes, or teardrop-shaped red cells.
The theory is that as red cells try to squeeze their way out of the fibrotic, scarred-up bone marrow, they get stretched and deformed, retaining that teardrop shape. Seeing prominent dacrocytes should make you think of myelofibrosis immediately.
The second cardinal feature is leukoerythroblastosis. This is the presence of immature granulocytes, like myelocytes and metamyelocytes, and nucleated red blood cells in the peripheral blood. The fibrosis disrupts the normal bone marrow architecture and blood-marrow barrier, allowing these immature precursor cells to leak out into circulation.
And the third feature is bizarre platelet morphology. You often see giant, hypogranular, strange-looking platelets reflecting the dysfunctional megakaryocytes that are driving the whole fibrotic process. So to put it all together, teardrop cells, NRBCs, a left shift, and giant platelets, that smear picture screams something is terribly wrong inside the bone marrow.
Absolutely. And that leads to the final diagnostic challenge. If you try to do a bone marrow aspirate on a patient with advanced PMF, what do you often get?
A dry tap. You can't aspirate anything because the marrow cavity is packed with fibrous tissue. This is why the bone marrow biopsy is absolutely essential. The biopsy core is what allows the pathologist to see the actual architecture, to stain for the reticulin fibers, and to confirm the diagnosis of myelofibrosis.
It's such a complete picture. The driver mutation causes abnormal megakaryocytes, which cause fibrosis, which leads to extramedullary hematopoiesis, which in turn gives you the splenomegaly, the teardrops, and the leukoerythroblastic picture we see on the smear. Every lab finding is a direct consequence of that initial molecular event.
Let's quickly summarize the Philadelphia chromosome negative MPNs, because the overlap in mutations can be tricky.
Polycythemia vera, primarily an overproduction of red cells, almost always JAK2 positive. Hallmark is a high HCT with a low EPO.
Essential thrombocythemia,
Primarily an overproduction of platelets, driven by JAK2, CALR, or MPL. Hallmark is sustained extreme thrombocytosis. Primary myelofibrosis starts with proliferation, but defined by marrow fibrosis, driven by JAK2, CALR, or MPL. Hallmark smear findings are teardrops and leukoerythroblastosis.
An absolutely fantastic summary. From the highly specific BCR-ABL1 of CML to the shared drivers of PV, ET, and PMF, we've seen how understanding the pathophysiology makes sense of everything we see at the bench. It's the difference between just identifying a teardrop cell and understanding that you're looking at the consequence of a red cell being squeezed out of a scarred bone marrow.
Well said. We've now covered the major categories of myeloid neoplasia. We've seen the failure to mature in AML, the failure to produce effectively in MDS, and today, the failure to stop producing in the MPNs.
It's a comprehensive look at what can go wrong in one half of our hematopoietic system. But of course, that's only half the story. The myeloid lineage has its counterpart, and a whole new set of malignancies that arise from it.
So I think it's a perfect place to wrap for today and set the stage for our next deep dive. We'll be crossing the aisle from the myeloid to the lymphoid lineage. We'll be tackling the acute and chronic lymphocytic leukemias, the lymphomas, and the plasma cell disorders.
I can't wait. It's a whole new world of pathophysiology and morphology. Until then, thanks for joining us on the deep dive.